A new treatment for patients is dropping soon. Remember the name, Baxfendy, also known as Baxdrostat. Baxfendy is coming soon. Baxfendy is almost here. Stay connected to Baxfendy. Visit baxfendyhcp.com. That's baxfendyhcp.com. Sign up to receive upcoming updates on Baxfendy.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. Thank you for joining us. This is Billy Joe Mullinax here. I'm one of the Interventional Cardiology Fellows at Emory and one of the two co-chairs for this PERT and CardioNerds PE collaboration series. Before we get into this episode, I'd like to take a moment to give a disclaimer that we recorded this episode before the 2026 ACC AHA new pulmonary embolism guidelines were released. So there, we're pretty heavily focused in the 2019 ESC guidelines. The new ACC AHA PE clinical categories triages PE on a scale of A to E. So with A being the lowest risk and E being the highest risk. Specifically, A was found or noted to be the subclinical and incidental asymptomatic PEs, B being symptomatic with a low clinical severity score, and they triage that down into B1 and B2 between segmental and non-segmental PEs. C's were symptomatic just like B's, but they had an elevated clinical severity score, and they further triage that into 1, 2, and 3, and they give a respiratory modifier. C1 were normal RV function and size, as well as normal biomarkers. C2, they have to have an abnormal right ventricle or one abnormal biomarker. C3 was abnormal right ventricle and at least one abnormal biomarker. And then the respiratory modifier was if they have an SpO2 less than 90%, a respiratory rate greater than 30, and need supplemental O2. Clinical category D was incipient cardiopulmonary failure, with then a further categorization of D1 and D2. D1 was transient hypotension, and D2 was normotensive shock. And then the respiratory modifier for clinical category D is if they need greater than or equal to at least 6 liters of nasal cannula or a non-rebreather mask, which brings us into category E, or cardiopulmonary failure. They stratify that into E1 and E2, with E1 being recurrent or persistent hypotension with shock, cardiogenic shock, and E2 being refractory shock or arrest. And then the respiratory modifier for that is persistent hypoxic respiratory failure or ventilator failure. So that is the difference that's in the new ACC 2026 pulmonary embolism guidelines. Don't worry though, we're going to spend an entire episode diving into these new guidelines very soon. And we're going to do that with the chair of the guidelines, Dr. Mark Krieger. Until then, thank you for joining us, and we're going to return to your previously scheduled broadcast.
Hey CardioNerds, this is Dinu Balanescu, Chief Cardiology Fellow at the Mayo Clinic in Rochester, Minnesota, and co-chair for the CardioNerds Pulmonary Embolism series. We're thrilled to bring you this high-impact episode, diving into the dynamic and sometimes controversial world of pulmonary embolism management. Today, we're focusing on one of the ongoing debates, the role of systemic thrombolysis in acute PE, especially in the age of evolving catheter-directed therapies. I'm pleased to introduce Dr. Billy Joe Mullinax, an interventional cardiology fellow at Emory in Atlanta, Georgia. He's an active member of the Trainee Council of the PERT Consortium and my co-chair for the CardioNerds PE series. Hey, Billy Joe.
Hey, Dinu. It's always fun talking to you. And it's a pleasure to be here and talk about one of our shared passions. PE remains a major cause of cardiovascular morbidity and mortality. And as you know, as cardiologists, we're often called to weigh in on who needs lysis or catheter-directed thrombolysis or embolectomy, which agent, when to pull the trigger on which therapy. Today, we're joined by one of our fit cardio nerds, Dr. Mariana Garcia Arango. She's a first-year cardiology fellow at the University of Wisconsin, where she also completed her residency in internal medicine. So welcome, Mariana.
Thank you for the kind introduction, Billy Joe. I'm thrilled to be here and learn more about the advances and therapies for pulmonary embolism care. Now, I have the pleasure of introducing our outstanding expert who lives and breathes this field, Dr. Allison Burnett. Dr. Allison Burnett is an adjunct associate clinical professor at the University of New Mexico College of Pharmacy, where she serves as the anti-thrombosis stewardship pharmacist. She is also the immediate past president of the Anticoagulation Forum. Welcome, Dr. Burnett.
Thank you so much. It's an absolute pleasure to be here.
Before we jump into the science, let me first say that I am thrilled to have a clinical pharmacist join us for our first recording. You all strengthen our clinical team in profound ways. In fact, I love them so much that I married one. So let's set the clinical stage. Imagine you're on call and you get a page. It's an ED stat page because, of course, and it's a concern for high-risk PE. They have a 62-year-old lady with a history of hypertension who presented to the ED with a sudden onset shortness of breath, with some chest pain and a pre-syncopal event. Upon arrival, she's found to be diaphoretic and hypotensive. Her blood pressure is 78/52 with a heart rate of 130. Her SpO2 is 89%. She's already on high-flow nasal cannula. Her blood pressure has remained low despite initial fluid resuscitation. Her high-sensitivity troponin was found to be 500 with an NT-proBNP of 1500. And her lactate was checked and found to be 3. They do a bedside echo and find that she has a dilated right ventricle with septal flattening and McConnell side. All this is consistent with acute RV strain. They do obtain a CT pulmonary angiogram, which confirms a large saddle PE. The ED team is wondering if they should push thrombolysis.
All right, now it's quite clear that we're facing a high-risk case and a high-risk situation and that there's no time to waste. Dr. Burnett, what goes into determining the eligibility of this patient for receiving systemic thrombolysis?
Yeah, well, I agree. This is a high stakes, high stress situation. And I think I heard in the case, the team was wondering about IV push lysis. So I think we'll get to that here in a little bit. But what this really comes down to is risk stratification. And I want to dive into what the different risk strata are for PE. But first, I want to just briefly talk about some of the evidence behind systemic lysis for pulmonary embolism. So historically, systemic lysis has been studied across both intermediate, or what is also known as submassive PE, as well as high risk or massive PE. And what that data shows is that meta-analytic data does show that there is a reduction in mortality, a significant reduction. But what's interesting, and I think what's important for our attendees to be aware of, is that if you take the high-risk PE studies out of those meta-analyses, that mortality benefit amongst submassive PEs is lost. And also important to note that thrombolytic therapy comes at a cost of increased bleeding. For example, in the commonly cited PYTHO trial that was published in the New England Journal of Medicine in 2014, this was a randomized controlled trial in which intermediate risk PE patients were randomized to receive bolus tenecteplase in tandem with heparinization versus heparinization plus placebo. And the primary outcome in that study was the composite outcome of hemodynamic decompensation or death at 7 days. And what they found was that tenecteplase bolus dosing led to a significant reduction in hemodynamic compromise, but there was no benefit with mortality. On the other hand, if you look at the data of high-risk PE patients, there is a clear mortality benefit. And so that's why guidelines have supported the use of systemic lysis for high-risk or massive PE, whereas they have not been as strong with their recommendations for submassive PE. So we really want to reserve systemic lysis, which again comes at that increased cost of bleeding. In the PYTHO trial, the rates of major bleeding were just north of 11%, with intracranial hemorrhage being around 2%. So we really want to reserve this systemic lysis for our most severe cases. And I would argue that this patient is falling into that category. Now, when we talk about risk stratification for PE, our most common schema that's used in clinical practice comes from the ESC 2019 guidelines. And they categorize low-risk PE as patients who are normotensive and have no evidence of right ventricular dysfunction. Then there's an intermediate risk category, and they actually break that down into intermediate high and intermediate low. And so intermediate low is normotensive patients without evidence of right ventricular dysfunction, but an elevated PE risk score. And intermediate high patients are those that are normotensive and have some evidence of RV dysfunction and elevation of their cardiac biomarkers. The high-risk patients very clearly declare themselves. These are the ones that are hemodynamically unstable with significant RV dysfunction. And I would argue that Our case patient falls into that high risk category. So if I was getting this call as part of the multidisciplinary PERT team, I think we would be talking about doing systemic lysis with alteplase or perhaps tenecteplase.
Very interesting. Gosh, you touched on so many things. One of the questions I had really planned on posing to you today was what you specifically quoted to patients for their risk of both major bleeding and fatal or high-risk intracranial hemorrhage. I personally quote the 2% from the PYTHO, but I know that some of the other studies suggest varying rates on those. And I know that we're talking specifically about systemic thrombolysis, but the CDT rates were sometimes 0 or very lower. And also, just like a little tid point, I also use the ESC triage for these patients. I think everyone at Emory, for the most part, does that. What about you guys?
Yeah, I think the ESC risk stratification is becoming more and more accepted, and it's not just used in Europe. Now, that said, it does have some limitations, and we're going to hear about these directly from the main author of the ESC guidelines in one of our dedicated episodes in the CardioNerds Pulmonary Embolism series on risk stratification. So stay tuned for that.
Yeah, I think as far as the rates of intracranial hemorrhage, that I also use that 2% rate. And I agree that when you look at the CDT or catheter-directed thrombolysis rates, I mean, they're much lower. And that's obviously one of the advantages of using catheter-directed thrombolysis, is that it's much more precision medicine and focused therapy, and you can actually use much lower doses of the lytic. Still, an intracranial hemorrhage rate of 2% is a significant increase from anticoagulation alone. So we do have to be careful in who we're selecting to expose to these lytic therapies.
Thank you for all of those important clinical pearls, Dr. Burnett. It's sure it's going to be really helpful on my calls as a first-year fellow. Our case continues. As Dr. Burnett mentioned, the team decided this patient would benefit from systemic thrombolysis. But just as we are preparing to administer the medication, the patient suddenly becomes unresponsive. She loses her pulses. CPR is initiated immediately. On the monitor, she's in PA arrest. No shocks are delivered. After 3 rounds of high-quality CPR and epinephrine, the ED attending random decode pauses and asks the critical question: should we give thrombolytics during the arrest? Dr. Burnett, what is the current evidence to use thrombolytics during codes?
Thank you for that question. So I think in the original case, we would have been thinking about giving some lytics and maybe giving it alteplase 100 milligrams over 2 hours. So that would have been a continuous infusion. This is a different situation. So I think that when somebody is in cardiac arrest and you're doing CPR, if there's high suspicion or it's confirmed that arrest is due to a PE, the mortality rates are extraordinarily high, and thrombolytics should absolutely be considered. We do have some registry data as well as some meta-analytic data showing that when lytics are used during CPR, that we have higher odds of attaining return of spontaneous circulation, or ROSC. And there may even be a 30-day mortality benefit with that. And so guidelines do support this. And I think one of the commonly cited trials that informs how we dose lytics in this situation comes from the PERT trial in 2016. In this trial, these types of patients received 50 milligrams of IV push alteplase, and nearly 100% of them attained ROSC, and more than 80% survived to discharge. So I do think that use of lytics in this situation is justified.
In this particular case, we had the privilege of actually having a diagnosis of PE before the patient coded, for what it's worth. In many scenarios, the patients just experience cardiac arrest or code without us knowing that diagnosis. And it depends on how much time we had with the patient before they coded for us to actually build that clinical suspicion. A lot of times that just doesn't happen. And there's significant autopsy data out there to suggest that it's not an uncommon situation. But to recap, the 2 main scenarios where systemic thrombolysis is considered are in high-risk PE with hemodynamic instability by definition, and in cardiac arrest due to PE, with some nuance in those intermediate high-risk patients. Now, with that foundation in place, let's shift gears a little bit. Dr. Burnett, would you please review the pharmacologic properties of the fibrinolytic agents we have available today?
Yeah, I'd be happy to. So I guess I'll start by saying that streptokinase and urokinase are older agents, and so we don't use them in practice. It's rare ever at all. So I'm not going to focus on those. The two main workhorse drugs that we have in practice are going to be alteplase and tenecteplase, and both of these are recombinant drugs that convert plasminogen to plasmin to help accelerate clot lysis. Alteplase is the wild type form of the molecule, and it has a really short half-life of about 4 to 5 minutes. And it's commonly given, as I mentioned before, it's given as 100 milligrams IV over 2 hours. That continuous infusion is needed because of that short half-life. There are other various dosing schema that perhaps we can get into in additional conversations later in the podcast. Tenecteplase, on the other hand, is a genetically modified form of this molecule. It has 3 point mutations or amino acid modifications that alter its pharmacokinetics such that it has a longer half-life of about 20 to 25 minutes, which allows it to be given as a single bolus dose. It also has higher specificity for fibrin, so it has less off-target effects. And then it also has a higher degree of resistance to something called plasminogen activator inhibitor 1. And that is a molecule that just basically blunts the response to the lytic. TNK or tenecteplase is less vulnerable to that. TNK has been less studied in pulmonary embolism, but there are some hospitals that are moving to tenecteplase because of the ease of administration of that bolus dose. There is some concern that there may be a higher bleeding rate with tenecteplase as compared to alteplase, but we don't have really good high-quality prospective studies to show us that.
Would you mind helping me out with one thing here? If TPA has a shorter half-life and tenecteplase is a longer half-life, is tenecteplase going to have as fast of an action to its peak, or is TPA going to be faster there as well, and then the tenecteplase is going to ultimately get there and just stay there for the longer period of time, thus have more risk of the bleeding?
That's a good question, Billy Joe. I'm not sure I know how to best answer your question, but tenecteplase has been established as equally or more effective therapy in a different population of acute ischemic stroke. So I don't think the efficacy is compromised or the time to max concentrations is compromised by its half-life, but I would welcome thoughts from anybody else in the room.
I had another follow-up question too, because my wife tells me how challenging it is to mix the TPA. Is tenecteplase even easier to prepare? I know you said it was easier to administer, but is it as easy to prepare or easier?
Full disclosure, I'm not down in the ED admixing TNK, but what I know from my ED pharmacist colleagues is that the short answer is yes, it's easier to admix. It comes in a kit and it's easier to administer. So that's one of the main reasons that a lot of hospitals have made the move from alteplase over to tenecteplase for stroke and are following suit for PE as well.
That makes perfect sense.
Thank you for those details, Dr. Burnett. To move along the pharmacology and going into the clinical aspects of TPA, what are your takeaways in terms of absolute and relative contraindications for this therapy?
Mariana, this is a good question, and I'm going to be interested to hear what your thoughts and everyone's experience in practice is. But the way I think about this, we always want to consider what are our patients' contraindications to receiving a clot busting drug that comes with, an appreciable risk of major bleeding. And so the first thing that comes to mind, of course, is our conventional absolute contraindications that we think of when we're going through our TPA checklist for, let's say, a stroke patient. Things like any history of intracranial hemorrhage, a major trauma or an acute ischemic stroke in the last 3 months, or active ongoing bleeding. I mean, I think we do at least need to stop and give pause to that. But what I'll pose to you all and also to our listeners is that the rate of mortality in massive PE, and when we're considering giving lytics, is extremely high, like more than 90%. And if you compare that to the rates of mortality in acute ischemic stroke, that's 5 to 10%. So we're going to have more pause in our stroke patients. But when you've got somebody in front of you with a massive PE that's going to die if you don't provide some type of intervention, I would argue that a lot of those absolute contraindications get shifted over into the relative contraindication column. And that opens up more room for discussion about giving a lytic to this massive PE patient at imminent risk of dying. So I'm not sure that there are a whole lot of absolute contraindications in this situation. Anyone else have any thoughts on that?
I agree. I will say that my experience is not as robust as yours so far. I'm only 7 years into my true medical career, not including med school, but we have seen situations much like you're describing. In fact, when I was on call about a month or so ago where we had a young patient who had a massive PE, we actually just finished a long case, but we were hearing the story and everyone's thinking, oh yeah, she's clearly massive, she needs lytic. And then the next part our general fellow is telling us is, oh, by the way, she had a spine surgery a month ago. And then we're all scratching our heads wondering what's the best thing to do for this lady. It ends up being a big conversation between a lot of people, and then the risk-benefit ratio is much like you're saying. At least in my experience, if there's a true intracranial mass or a recent stroke, certainly within the last 3 months, we're really going to be hesitant to pull the trigger on the systemic lytic. But, in this case, it was a lumbar spine decompression. It's like she's 4-6 weeks out. That's probably okay. Can we call the spinal surgeon? And it ends up being a true PERT discussion, which I think is what's the beauty of a PERT team. But to have more than one opinion on something, especially when someone's life may be determined in the next half hour, much like you're describing.
Billy Joe, that was very interesting. And now that you mentioned, I'm very interested to hear everyone's opinions and thoughts on how have the PERT teams impacted the care of PEs on your institutions. For example, right now, a first-year fellow, we've had a lot of training on how does that look like. And as the first responder to the PERT calls and pages, I've been involved in multiple situations, but I would like to hear more from your experience throughout these years.
PERT efforts at our hospital, I think, have absolutely positively impacted patient care. And not just for, I will say, in regards to overall stewardship, because PERT teams are a perfect example of providing stewardship over pulmonary embolism patients. So in my experience, we have built an infrastructure where we have real-time notifications of pulmonary emboli, and we convene the multidisciplinary PERT team on a direct messaging thread. We risk stratify that patient in real time with the PERT providers. And we not only identify patients who may need to go for an escalated intervention, et cetera, we're also quickly identifying those low-risk patients that don't need a lot of resources, and we can get them out of the hospital really quickly. So hopefully that's allowing us to free up resources to be deployed to more complex areas. But yeah, having the multidisciplinary team and being able to get care into place much quicker and being able to have that multidisciplinary discussion that Billy was talking about, that's been invaluable in providing optimized patient care for our PE patients.
While PERT data is still very much in its infancy, I think the time to decision is a parameter that's been consistently demonstrated to improve in the presence of a PERT team. And it's fascinating to see the difference between different PERT approaches at various institutions. For example, at Mayo Clinic, where I'm currently training, we have a brand new PERT. We have some growing pains, but we're learning. And I think that might tie right into Billy Joe's next question.
Thank you, Dinu. Absolutely right. By the way, I love PERT. Yeah, here at my fellowship, we have so many hospitals that actually PERT looks different depending on which hospital I'm covering on a particular day for call. But it is usually a conversation between at least two people, and then sometimes it can be a little bit more involved than that. So thank you so much for walking us through those points. Your expertise is definitely showing through. Now I'm going to ask you the next question. This one's a little tough, and my bias as an interventionalist is going to show through here. But what does the future of systemic therapy for PE look like? And do you think systemic lytics still have a place in the management of PE with the rapidly growing field of catheter-based therapies?
Yeah, what a great question. Does systemic lysis still have a place in therapy with all of the emerging catheter-directed approaches? My first thoughts are yes. I think there are going to be niche situations, and so it would be great to have more and perhaps even better data on systemic lysis. A couple of situations I can think of is one, if their presentation is so severe and you don't have time to mobilize your interventional or procedural team to do some type of catheter-based intervention, and you just absolutely need to get lytics on board as soon as possible, I can see that being an important role for systemic lytics. The other one that I can think of, I live in New Mexico, and so we have a lot of rural outlying hospitals that don't have the expertise to do catheter-directed therapies, but sometimes they have PE patients that, at least initially or maybe eventually, if they decompensate, require or are deemed to need lytic therapy. And I think that's another situation in which having systemic lytics as a tool in our toolbox would be really essential. I'll mention that there's some ongoing clinical trials, one being the PYTHO3 trial that's looking at a reduced dose of systemic lytic compared to anticoagulation alone. And I think that's a really well-designed trial. I think it'll provide us some additional insights as to the role of systemic lysis and can we get away with lower doses that, based on the existing studies that are out there, suggest that there's similar efficacy but a reduced rate of bleeding. So I think that's encouraging. You know, it's interesting that there's been a handful of trials that have looked at reduced dose alteplase. So instead of doing the 100 milligrams IV over 2 hours, the trials have done 50 milligrams, or they've even done a weight-based approach of 0.6 milligrams per kilogram in a few trials. Those trials do show encouraging results with less bleeding. What I find interesting is that, you know how in the stroke population, they've studied lower doses of tenecteplase. They started out with 0.4 milligrams per kilogram, and then more recent trials have shown that a lower dose of 0.25 milligrams per kilogram, equally efficacious and safer. I'm wondering, or if you guys have ever thought about, why has nobody done a reduced dose T&K trial? Because right now, T&K is dosed at 0.5 milligram per kilogram, anywhere from 30 to 50 milligrams based on the patient's weight. But what if we could use even lower doses of tenecteplase, which is easier to use in practice? Might that promote an even, I don't know, stronger role for systemic lysis in our select patients?
It's honestly a really good point. I have a mentor down here who strongly believes in a reduced dose and a reduced rate of infusion over a longer period of time. Specifically, this has to do with TPA, but I think you bring up a good point for T and K. Either way, if you reduce that risk of bleeding and you still get the same benefit, especially in those rural areas where they may not have advanced therapies, or for patients who may not choose it. We've definitely seen patients who, if given all the options, choose a conservative option. And especially if we have a good therapy, now it may come with a higher risk of bleeding, albeit a low one if you reduce that rate and time, but I bet patients would choose it from time to time. During our most recent PERT symposium, we had some scenarios that we posed to the crowd. It was a series of questions in a survey that we're actually going to be publishing. It's going to be pretty exciting. But we saw very different practice patterns for several clinical scenarios, and some of those I think will be right up your alley. We had one was regarding anticoagulation during and after lytic therapies. Can you tell us what we should be doing with our heparin drips or other systemic anticoagulation when we're considering or have already given lytic therapies to patients?
Yeah, really excellent question. And yeah, I've been at several PERT meetings where this topic has come up and agree that there's some degree of disagreement. And I'm glad that we didn't start with this question because it probably could have taken up the entire time. But what I'll do is unpack and touch on a couple of questions that I think come up most common in my practice and that I've had the most discussions around. So the first one has to do with, if you need to utilize initial parenteral anticoagulation, what should be your parenteral anticoagulant of choice? And we have meta-analytic data and we have guideline recommendations that say for most PEs and overall acute VTEs, we should be opting for low molecular weight heparin over IV unfractionated heparin because the data suggests that there's a significant reduction in the rates of recurrent VTE. There's reductions in major bleeding, which is likely due to the fact that low molecular weight heparin is a more specific and predictable drug with fewer off-target effects compared to heparin. So for the majority of acute PEs, I would argue that we should be opting for low molecular weight heparin. I think where the challenge comes in is that we haven't had adequate studies on that question in patients who are undergoing advanced procedures, catheter-directed lysis or thrombectomy, et cetera. But I'll point out that a lot of the early trials, including with systemic lysis, actually preferred or allowed low molecular weight heparin. So studies like PYTHO and like Topcoat and Moppet. So this isn't unprecedented to use low molecular weight heparin even in systemic lysis. And then it's also interesting to look at the catheter-based, the suction embolectomies, et cetera, those trials that are ongoing like PE Tract, et cetera. They're actually calling for preferential use of low molecular weight heparin in those patients. And so I think this stems from the fact that there are a few studies out there that suggest that when patients have an acute PE and you're trying to heparinize them, they're not achieving adequate levels of anticoagulation in a timely fashion. And we know from much earlier studies that when patients aren't adequately heparinized within a certain time frame, they have a higher risk of recurrence or progression. So I think it's an important conversation. I'm not sure we have any good answers, and we definitely could use better data. But I would say for the majority of patients, we should be using low molecular weight heparin as our initial parenteral anticoagulant. I think exceptions to that rule would be patients with perhaps severe renal impairment that might experience accumulation if repeat dosing was needed in the immediacy, or understandably, if somebody was expected to be, for example, cannulated for ECMO, right? Sometimes we put these massive PE patients on ECMO. I think that's a situation where heparin is the preferred anticoagulant in ECMO, so I think that's certainly an exception to this. But I will say our protocol at University of New Mexico Hospital, we prefer low molecular weight heparin except in those niche situations of severe renal impairment and potential ECMO, which makes some people uncomfortable if lytics are going to get introduced to the equation. So that's one area where I think there's a lot of discussion and controversy, and would like to see some stronger recommendations around those patients going for advanced procedures and what would be the best approach. The other topic that comes up is how should anticoagulation be managed during systemic lytic therapy? Also an excellent question. And I will say, if you read back through the earlier studies, oftentimes they don't go into great detail about exactly how this was executed. Was it concomitant? Was it sequential, et cetera? There are a few exceptions to that, and some of the studies explicitly say that they wanted to have concomitant therapeutic anticoagulation going while the patient was receiving an alteplase infusion or after they had received tenecteplase bolus. And from my understanding, the rationale behind that is that when you're lysing clots, as that clot is being broken down, it's releasing prothrombotic materials and clot fragments and exposing prothrombotic surfaces. So you could actually get regeneration of thrombin that could form new clots. So using the lytic in tandem with ongoing anticoagulation actually provides better protection for that patient against recurrent or progressive PE. So I've seen different approaches in practice, and I'm sure you all have read about different approaches in practice. I will say that at our institution, we actually allow for continued heparinization if we're giving an alteplase infusion, which aligns with some of those earlier trials. But there is variation in practice, and some protocols call for interrupting heparinization during the lytic infusion and resuming near or the end of the infusion and resuming without a bolus and only when the APTT is less than 2 times the upper limit of normal. My point here is that there's no consensus on this and there's no high quality evidence to inform it. So there's going to be variation in practice. And this is another area where antithrombosis stewardship becomes vital, because you need to have multidisciplinary discussion, multidisciplinary decisions, and multidisciplinary agreement on what your protocol is going to be at your given institution. And understanding that protocols are meant to cover 80% of patients. So there's always, even if you have a protocol in place, there's still going to be those 20% of patients where there might need to be deviation. And again, you're going to have multidisciplinary discussion around that. Billy Joe, I think I warned you at the top of this. I could go on and talk for days, and that probably was a more long-winded answer than you wanted, but I agree it's a fun and interesting topic to talk about.
Honestly, I loved every second of it. In fact, I was sitting there thinking to myself, goodness, if I'm going to continue my heparin during my lytic, am I going to use that as a fixed rate at, say, 500 an hour, or am I going to use that a low standard heparin drip, or am I going to keep on the high standard? But then you went right into it. You said that people disagree on it. There's different protocols, and I'll bet that's within one institution. Each provider has their own little twist on it. So there really is no set standard. So that gets right into the heart of the question that we posed at the symposium. And I think that lays down some groundwork that we need to come up with something together and find a good way to do these for this patient.
Yeah, I fully agree with your comments. I think because of the variation in the way all of the studies were conducted with the different regimens and the lack of details, I think it's just led to this huge gap, and we need better information around this. So hopefully all these clinicians that are conducting these clinical trials, I think they're catching on to the fact that they're exactly what the unanswered questions are, and they're getting more detailed and providing more explanations about exactly what their protocols are going to call for.
Thanks, Dr. Burnett and Billy Joe, for those comments. I wanted to recap and summarize for our audience the most used anticoagulation for 3 specific instances. 1, when we use lytics, 2, when we use catheter thrombectomy, and 3, ECMO. Just kind of like to summarize in those 3 clinical scenarios, like what would be your preferred anticoagulation or choice when you're going to use lytics versus catheter thrombectomy versus ECMO?
Great question, Mariana. And starting with ECMO, I would say for ECMO, clearly the most evidence lies with unfractionated heparin. And so in patients that we are anticipating may need to go on to ECMO, I think certainly unfractionated heparin would be the drug of choice. I think for patients also that are going to undergo systemic lysis, I think those patients are high risk enough. Obviously, they're high risk, or we wouldn't be considering systemic lysis, that IV unfractionated heparin could be justified. I will say that for patients undergoing catheter-directed procedures, now remember, we have 2 basic types of catheter-directed procedures. We have like thrombectomy, and then we have catheter-directed lysis. At my institution, I will say that patients undergoing either of those procedures are eligible for low molecular weight heparin. And as I mentioned, some of the thrombectomy trials that are ongoing, like PE tract, et cetera, they're actually calling for preferential use of low molecular weight heparin. And again, I think the thinking is that it provides more consistent, more rapid anticoagulation compared to heparin. So I would say in thrombectomy situations, catheter-based thrombectomy, low molecular weight heparin would definitely be first line at our shop. And then I think for catheter-directed thrombolysis, I think that's where people get concerned, because it's just the introduction of the lysis. And so they feel that if the patient ended up in a bleeding situation, they would want something that was fully reversible with the shortest half-life. And so I think that there's definitely room for discussion there. And again, protocols have to allow some flexibility. Either low molecular weight heparin or unfractionated heparin could be reasonable in that situation.
So the future may not just be more lysis or less lysis, but smarter lysis therapies that combine potency with safety by being more selective. Dr. Bird, what are your main takeaways for our cardio nerds today?
Yeah, main takeaways would be, I would say first, systemic lysis can save lives, but it needs to be used in the appropriate people, which is really mostly just our highest risk patients. For my second takeaway point, I would say there's no standardization around the anticoagulation that we use in conjunction with lytic therapies. So make sure that you're developing standardized, agreed upon multidisciplinary protocols, taking into consideration the evidence that exists, and hopefully ongoing clinical trials will provide more details and more guidance on how we should be approaching that. And then my third takeaway would be that as an antithrombosis stewardship pharmacist, I would just say, if you don't already have one, encourage the development and implementation of a PERT team at your institution, because this is a solid way to promote optimized care of our pulmonary embolism patients.
Thank you so much for joining us. Before we wrap up, we do have one last question for you. In a true CardioNerd style, what makes your heart flutter every day?
Okay, the medical professional answer is a well-executed PERT call that leads to good patient outcome. But the more honest answer would probably be puppy videos on TikTok.
That sounds about right, and I think we all can sympathize with that sentiment. And what a great episode we had today. Dr. Burnett, huge thank you for sharing your knowledge and wisdom with us. Many thanks to Mariana and Billy Joe as well for moderating our discussion, to our listeners for joining us on this journey, and to the PERT Consortium for their collaboration on this series. P continues to represent a major cause of cardiovascular morbidity and mortality. Systemic thrombolysis, while associated with bleeding risk, remains a potentially life-saving therapy in appropriately selected patients. As this therapeutic landscape advances, especially with the advent of catheter-directed and pharmacomechanical options, the central challenge remains optimizing this balance between efficacy and safety through individualized, evidence-based decision-making. Thanks again for listening, and we'll see you on the next episode of the CardioNerds Pulmonary Embolism series.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeComm Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.